Welcome to the Penn State College of Medicine COVID-19 ECHO series for skilled nursing facilities. We're delighted to have you join us for today's session. My name is Jackie Sable. I'm a member of the ECHO team, and I'll be facilitating today's session. A few announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box. We ask that you stay muted unless you're speaking during the session. If you're on a phone, you can use *6 to mute and unmute, or you can use the microphone icon on the bottom left side of your Zoom screen. You can also use the chat for communicating. We realize that question and answer time is important to you, and we try to categorize and address as many questions as possible during the session, but if there are any open items afterwards, we always follow up. If you have questions or suggestions for future COVID-19 ECHO topics, especially for the skilled nursing facilities, please share via the chat tool, or you can always email us at echo@psu.edu. Please remember that if we do begin talking about cases, no personally identifiable information or PHI is allowed. We are recording these sessions, and we share all materials and recordings after this session. In the spirit of ECHO's all teach, all learn model, we'll be on a first name basis during the session. Today's session will include a lecture focusing on lessons learned for skilled nursing facilities during the pandemic. We do have a team of experts from Penn State Health online. They'll monitor the chat, as will I, but please feel free to put questions and answers into the chat, because again, we are an all teach, all learn. So I am going to turn things over. We have a team of 3 people who will be presenting today, and I'm going to turn it over to Ayesha to start, and then I'll ask each of them to introduce themselves as they go through their lecture.
Thank you. Hi, everyone. So my name is Ayesha Ahmad. I'm an internist and geriatrician with Penn State Health, and I'm part of their post-acute care team that provides care to some of our partner sites in central Pennsylvania. Presenting with me are Kelly Thrush and Loretta Tuchin, who work with me in one of the facilities, and they have really handled many aspects of the COVID crisis that we wanted to share with you. I think a lot of you who work in long-term care have handled or seen an outbreak. And I'm not saying that the outbreak in our facility was unique. Neither am I going to give you some amazing medical data about the use of remdesivir or intravenous vitamin C or some other protocols. I think our presentation is really far more pragmatic and deals with the nitty-gritty details of, you know, okay, it happened and you have a huge outbreak, and, you know, how do you handle it, and what are some of the things we learned during this? I think we were in the front end of the outbreak, and it happened to be a large facility. So here I go. Sorry. So I think you'll all agree that COVID-19 is ravaging our long-term care facilities. Ravaging, decimating, these are strong words, but I really cannot think of kinder words to state this. Also, nationally, 40% of all COVID deaths are linked to skilled nursing facilities. When I pulled Pennsylvania statistics yesterday, we've had more than 73,000 cases, and we've had 5,742 deaths. Out of those, 11,000 cases have happened in Pennsylvania's long-term care facilities, and the total number of deaths that have happened in the skilled nursing home setting are 3,689, which means 65% of all COVID-19 deaths in PA have happened in areas where all of us that are attending this session practice in. So remember, we have about 700 facilities in PA. Right now, 218 have reported cases, but these numbers are not updated necessarily in real time, and some have not shared their data. So I'm sure the number is a little higher. So let me introduce you to our facility. It is one of the facilities where our post-acute care team disseminates care. It is the largest in Doffing County and one of the largest in Pennsylvania, which, you know, is made the whole thing a little bit more challenging. It used to be the previous county nursing home. It has 404 beds, 2 buildings. Each building has 4 floors each. So even their rehab floor, which in many other nursing homes comprises 20 or 25 beds, their rehab floor is 54 beds. They also have a respiratory and an on-site dialysis floor, which is a little different than many of the other skilled nursing facilities where we work. They have 2 DONs. Their average number of admissions pre-COVID was definitely robust. They don't just decompress Penn State, but they take a lot of admissions from UPMC Pinnacle and Holy Spirit. And right now, the 2 large post-acute care teams, there are one is us, but our census there is not that big. The other one is a community physician group. So Kelly can share those numbers with you eventually, but when we started, our census there was in the mid-40s, and obviously it shrunk post-COVID from deaths and low transitions. The other team has a far bigger census. So I'm sure that everyone who works in long-term care and has been paying attention to all the health alert networks or the HANs that come from DOH is literally inundated with HANs, right? So I kind of looked at the historical content. The first HAN we got from DOH was January 19th, when it all talked about this mysterious outbreak in Wuhan, right? Then January 25, the HAN talks about how to collect specimens. March 6th is when the first case in Pennsylvania was reported and a health alert network came out from the DOH. March 11th is when the first HAN came about wearing PPE, isolation, and limiting visitors. March 12th is when CDC recommended no visitor policy for nursing homes. We kind of fast forward to April 3rd, when universal masking was implemented based on a CDC guideline that had happened one day prior, which is April 2nd. Moving along the timeline, on 4/14, if you guys remember, the first HAN about cohorting residents in nursing homes came out. 4/16, the HAN came on screening visitors. Trying to remember, on 5/1, it's cut off on my screen. I'm not sure if I can review it. 5/12, we were talking about test-based strategies. And just a few days ago, the HAN about, testing more extensively, both residents and providers in nursing homes came out. So these are some of the notable HANs I selected, but if you go on the DOH page, you'll realize that there is, literally every 2 days, a new health alert network was coming out. So here is how things sort of unfolded at our facility. On March 12th, we had a very robust and a very engaging advisory board meeting for all the medical teams, the dialysis team, the consultants, the wound care team. And I remember, a very engaged discussion about how this crisis is coming. And, some people saw it coming and some people didn't. March 13th, the no visitor policy was implemented in our nursing home. April 2nd was the first patient with symptoms. He was sent out with a test pending. He was not under our team. He was under the community medical groups team. He was sent out the next day. On April 4th, we found out that he's COVID positive. So basically, within a few days, we had a full outbreak on one of the floors, which is called South 2. And then we also had one sudden unexpected death in a declining patient who had been declining for various other reasons, but she kind of died unexpectedly one day. Slowly, the outbreak spread to South 1 and South 4. So by the third week of April, it was on 3 floors. By early May, every single unit except one long-term unit had positive COVID cases. By mid-May, even that one unit kind of lost its luck. And every unit was basically on fire. Our respiratory and dialysis unit did manage to sequester, because even though they reported 3 cases, they managed to cohort them very quickly. And thankfully on that unit, the infection did not spread. There was a severe staff shortage. I don't have the exact numbers as to how many staff called off, some because they were sick, some because they were quarantined, and some out of fear, I suspect. National Guard had to be summoned end of April. I mean, that was probably the lowest point for a lot of us. National Guard initially came for 3 days, because I remember clearly they said our mission is to support a crisis for 72 hours. But knowing how bad things were and knowing how severe the staff shortages were, they kept extending, and they ultimately stayed through May 17th. So much longer than anticipated. So here are cases over time. I did not do day by day. That would have been cumbersome. So I kind of skipped days in between and went every 2 to 3 days. So you can see the graph. We went from 5 cases on April 5th, 29 cases April 21st. We crossed the 100 mark on May 8th with 104 cases. We kept climbing up. May 18th, we were 164. May 26th, we were 190 cases. June 3rd is the last count I have, 198 cases. So that's, I feel like, a staggering number, probably one of the highest cases I saw on the DOH site, where they list all the nursing home data. Or, they've been doing that since May 19th. So our final toll to date, I'll change that number because I think it's 199 cases, 40 deaths, 35 staff. If I'm not mistaken, 14 deaths happened in the hospital and the remaining deaths happened in the facility. So with that final toll, that sobering toll, I'll pass it along to Kelly. She has the next few slides to share with you.
Hi, everyone. Yes, I'm Kelly Thrush. I'm one of the nurse practitioners on the post-acute care team with Loretta and Dr. Ahmad. So what we did as a team, we just looked back and through everything over the last 2 months that we've been through with COVID starting in the building and then spreading throughout, and looking at, hey, what did we learn from this? What could we have done better, or what actually worked and what helped? So that's what we're going to be going over. It's not like we did all these things great, but looking back, this is what we learned about how we could prepare for this, hindsight. Main thing is, so looking at transitions of care, as far as any patients transferring in to our facility from the hospital, transferring out into the community. Main thing is the facility needs to be prepared. And one of the ways that was very helpful is, for sure, making sure we had enough stock in PPE, but also heat maps. So we have 8 different units at our facility, and so a lot of beds that we got to be keeping track of. And that's basically a diagram of every single unit with all the beds. And so whenever a patient tested positive for COVID, then that we used the color red, that they were positive. And so that block for that room was turned color red. And then we also used the color yellow, as well as green. So we did different colors, a color for if a patient was recovered, a color if they tested negative, and a color if that room was empty. But most important thing is if we could keep that up to date and keep it live and active on a daily basis, it would even be great if we could do it twice a day, because, you know, the numbers change from the morning to the end of the day, depending on how fast the spread was, especially at the beginning. And then also making a note of the date, when was the test positive, and then after so many weeks, if they were retested, what date they tested and if it was negative. So just having all the data in front of you was very helpful as far as looking at a unit floor plan. If the facility is able to hold and stop any new admissions, that would make things a lot easier as far as prevention and mitigation of COVID. And we did take readmissions of the patients who were positive, who were sent out to the hospital, and then we did take them back. But as far as any new patients coming in, we held off for a period of time. At one point, you know, it wasn't required for patients leaving the hospital to be tested for COVID. And so some of our positive patients, and the testing came from patients who were new admits to our facility. Most likely they were positive before they ever arrived to our facility, but they were never tested prior to arrival. And so looking back, that would have been one of the things that we could have done beforehand. But at that time, there weren't enough resources as far as test kits to go around. And then Loretta's going to be talking later about cohorting, but if we could cohort our admissions, what we did was we cleared out 2 different halls of a unit and made sure all our admissions went to those units, and that unit with those halls, and then we'd have them quarantined for 14 days, watching for any symptoms and monitoring, but making sure all our new admissions were kept together, and not mixing with the rest of our facility. The other thing to consider is with admissions, you got to think about if you are taking admissions, what type of support, what type of care and time is required, because we had a staffing shortage. And then whenever we're taking admissions coming into the unit, some of them were wanderers. They had a history of falls, they had behaviors, non-compliance with wearing a mask, non-compliant with staying in the room and self-isolating. And so that put even more of a strain on our short staffing. And then of course, if we had any patients who were positive with COVID when they discharged, or even if they had a roommate who was positive when they discharged, contact any PCP and specialty providers that they were following up with. So close follow-up was necessary, and we passed that on to the primary care providers.
Oh, sorry.
Another thing was we had a huge facility, and looking back, it would have made things a lot better if we could have kept staffing consistent on each unit instead of moving them around from unit to unit, whether it be at least to keep them on the same unit the same day. But even if we could have kept them on the same unit for at least a whole week or for the whole time throughout, that would have been better than them. Because if they were an asymptomatic carrier, then they could have spread it to other units without knowing it. And all staff need to have the same education and training. What I'm referring to is day staff, evening staff, night staff, all the different shifts they need to have and be educated with the same training and be audited as far as to know if they're doing things properly and to be held accountable to make sure even if the day shift is doing everything right, things are going to fall through the cracks, and it's going to spread throughout even easier if the afternoon night shifts don't have the same education and aren't being held accountable. So as far as staffing, number one, teamwork. Administration, nursing staff, all support staff, housekeeping, maintenance, and the medical services staff. We need to be on the same page. We need to be communicating with each other in order to work together and have a unified front against this spreading throughout the building once it's in. It's very important to have administration and the medical staff, as far as the medical services, being visible on the units for the nursing staff to see that, hey, we're here to support you, we're in this with you, taking care of the patients, doing our job just as you're doing your job. Because it makes it very hard for staff not to see any presence of administration. They may hear orders, recommendations, and directives coming down from administration, but if they don't see administration visibly and in person on the units, then they may think, if they're not doing it and they're not down here with me, then why should I be putting my heart and soul into all of this? Again, all shifts need to be very vigilant. Can't wash your hands too much, keeping your hands away from your face, and doing it every moment that you're in and out of a patient's room, before and after taking gloves on and off, before and after a procedure, before and after coming in and out of a room, before and after taking off any piece of protective equipment. One thing that was helpful was whenever we were finally able to get a hold of reusable gowns. And that way, there was a gown shortage, and if whenever we were able to get a hold of reusable ones, then they could be washed and used again without worrying about running out. Of course, making sure that you have enough supply of gowns, the face shields, N95s, surgical masks, and gloves. And then making sure staff is fully educated on how to preserve any of the PPE. For example, we have these face shields that are supposed to be just a, daily use, disposable. But yeah, as long as you clean them properly, then there's no problem with reusing them. But if the equipment, if the PPE is not cleaned and disinfected properly, then again, that's another way that COVID can be easily spread throughout. The main thing is for the nurses, and a common area needs to be arranged and made available with easy access for nurses, so they can, still be social distance, but be able to have their lunch without going in and out and spreading throughout the facility. And just even for the patients, they need to be informed and also have their own masks to use. They should be staying in their rooms and self-isolated. If they do have a need to come out of their rooms, they need to have a mask on at all times. Again, with staffing, needs to be very vigilant on watching the patients who are non-compliant and wondering about. But if we could make sure the patients continue to stay in their rooms for any meals. So another point of discussion was, when do you declare the patient's recovered from COVID-19? And again, this needs to be a united front, a discussion between the administration, the medical teams, and then whatever is decided, staff need to know, because they're communicating with families as well, and then also communicating with the patient. So, I mean, you do it after 2 weeks, 3 weeks, a month. Pretty much arbitrary, but the longer you wait, the better, the safer. We have had patients that were tested after 3 weeks, 21 days, and they continue to test positive. And other considerations are, do they still have any symptoms? I know, depending on the resources that are available, they may only test one time or may just go off of symptom resolution. You also need to consider about what are the chances of having a false negative. Then discussing, okay, if and when we declare somebody recovered, when is it safe for them to actually move from one unit to the next, back to their home room where they consider their home.
Yeah, I think we had, if I can interject here, Kelly, we all know that we have the CDC guidelines about test-based and non-test-based strategies. But I feel like a lot of our patients defied those generic guidelines. So there was a lot of discussion back and forth between our teams as to, whether those guidelines work for us or whether we need to be far more stringent. And I think we've been consistently surprised because some patients are continuing to test positive. I'll pass on to Loretta.
Hi, I'm Loretta Tuchin. I'm one of the nurse practitioners on the post-acute care service. So what we're trying to figure out is when to test people. We certainly know that we want to test them when they're symptomatic with the classic symptoms and some of the atypical symptoms. But because we work in the geriatric population, we're looking at people and saying, hey, they just don't look right, or they were doing this today, which is a behavior that they've never done before. Is it possible we have so much COVID in the building? Should we be testing these people anyway, and going ahead and testing people whether they were having those classic symptoms or not? So then as we're going through and we're testing people because they're symptomatic, we're also testing their roommates. And some of the rooms where we have a shared bathroom, not just for two people, but on two rooms share a bathroom. So not just the roommate, but the other room, because if they all use that restroom, then they're all exposed. So that created more and more testing in the facility where we were. The other thing that we need to look at is looking at the staff and where they were assigned. So the first floor that we had when we first had the outbreak kind of was a staff assignment. If we could look at where the positive patients were. And so was it a staff member that gave it to a patient and gave it to another staff member and it walked through that whole assignment? Or was it a patient who went out to an appointment somewhere and came back with it and shared it with the rest of the staff on that floor? It's very difficult to figure out where it came from. All we really know is that we really need to test people to see whether they're positive or negative, and if we need to cohort or do other things with them, or test the people down the hall. So actually we've gotten to the point where if we have somebody positive, we're testing in the areas where the next door neighbor isn't connected. We're still testing that next door neighbor because we're looking to see if there's a possibility that it was, staff moving it back and forth as well. We also ran into testing supply shortages where we were being rationed how many tests we could have on a single day from the facility where we sent our tests to, and we had to outsource and get testing done from another facility that could accommodate, because the building is such a large facility. We had just so many tests that needed to be run every day. So the shortage kind of made us try and really think hard about who we were going to test today and who could wait for tomorrow. If we really want to test those people that are symptomatic and maybe test the roommate tomorrow. The other thing that we sometimes saw was negative tests, and then a few days later, symptoms starting with people and needing to retest them a few days later, and then they come up positive. So there was a lot of lessons learned with the testing and false negatives. coming through on people that later tested positive. So just being vigilant is very important, because you don't know who's going to turn up positive next. You just have to consider everybody positive and get your PPE on, wear it, and wear it right. So in nursing homes, there are no negative pressure rooms like you get at the hospital, which is a wonderful thing. So you're kind of working with what the environment is. So there's some facilities have windows that can open and some don't. Our windows do not open. We don't have any negative pressure. So whatever was in the atmosphere is what we were working with. Our first floor that was affected was kind of self-cohorted because it seemed like a nursing assignment. We did have a few other people on the floor that were positive, and they were people that wandered and were in and out of that area where the positive patients were. I've got to give a lot of credit to the staff on that floor. We had a half a floor that was positive and a half a floor that was negative. And that half a floor that was negative, that staff worked really hard and kept that half a floor negative. We didn't have anybody convert on that first hallway. The whole idea of cohorting had a lot of conflicting information, and information changed constantly as we were trying to work, because it was so early on that our building was affected. So we were told, cohort, don't cohort, leave them in place. So at some points, with the first floor, we didn't move anybody. When we started having other floors have positive cases, we started moving some of those positive cases so that all the patients were on floors that were positive. But where you have one, you have 10. More and more of the floors were becoming positive, and then we started leaving those people in place because we could not keep moving everybody. We did have the one we have one COVID-free unit right now. There was a couple of positive patients that were quickly moved off the floor. And that is our unit where we have our respiratory patients and our hemodialysis patients. Those hemodialysis patients on that floor were getting home dialysis. So they were staying in their rooms, in their beds, getting their dialysis 4 days a week. At the beginning of this, before this all happened, the facility was talking about putting a den in so they could dialyze more people at a time in one area, and putting different kinds of machines in. And as this came about, they kind of reacted more quickly with that and got the dialysis den in place. They were sending out a lot of people to dialysis centers, not sure if we're sending things out, if we're bringing things in with these people that are going in and out 3 days a week. So the thought process was that we would be keeping everyone safer by doing dialysis in the building for as many people as we could get to do it. So there are still 2 people that are not going down to the dialysis den that they're allowed to say that they don't want to have dialysis in the den, that they want to go out to their dialysis center. So there's only 2 people left that are going out to their dialysis center. The rest are going down into the den and having dialysis right there in the building. So hopefully that's keeping exposure a little lower as well. And then emotional distress. As we started all of this, people were so afraid of COVID-19. There were people calling out sick because they didn't want to work with the patients that were COVID positive. That I heard of a few people that had even quit over this because they didn't want to go to positive units. And it really is, it is a difficult situation. People were afraid for their families to bring something home. It became a lot of stress on everybody. The nursing supervisors, that nursing supervisor that we have on that floor that was first affected is a very dynamic nursing supervisor, and she did wonders under a very stressful situation to keep her staff very calm about taking care of these COVID-19 patients. She is awesome. Anyway, it was very stressful for them. They were the floor with the most people in the beginning that had the patients that were sick and dying. So as people were getting sick, if they were COVID status, to be a full code, we were having to send them out to the hospital. Other people were, you know, their family members, or they had decided that they didn't want to be a code, and they were getting sicker and sicker on the floor and passing on the floor. And it was very stressful for the staff because these patients have become their family. And to watch these patients just get sick and die was just emotionally racking for them. The facility brought in some psychological support from a group that they used to come in to help with the patients. And I believe that the National Guard also brought in some assistance, and Penn State sent in some assistance as well on a different day. The staff there was allowed to, you know, reach out to them on a one-to-one basis or go as a group to try and help them get through the emotions of all this. There were, you know, we had 40 people pass away, and that's a lot. These people have been living there for quite a long time. So there was, that part of it was very hard on them. The tears were just unbelievable. And they kept going. You know, it was important for them to continue to take care of the people that were there as well. And the other thing that I wanted to touch on with this is staff illness. We certainly were asking people when they came into the building, you know, have you had a cough, a shortness of breath, you know, the typical classical symptoms, and taking their fever. But it wasn't until a few weeks into all of this that we started to ask about the atypical symptoms, the loss of taste and smell. And we found staff that were coming into work with atypical symptoms. So the emotional distress for them, not realizing that they were sick and having to be sent home to isolate. We certainly had staff that, you know, in a good situation, their home situation wasn't good to isolate, and they had a lot of difficulty isolating at home so that they didn't make their family members ill as well. So just very emotional for everybody involved with the patients being sick, the staff being sick, the short staffing because staff was sick. Just a very tough time for everybody emotionally. And as we're seeing patients start to recover, we're starting to see that sigh of relief on the floors as their stress level is going down. But we're trying to maintain that ever vigilant. You need to keep your PPE on because we're not really sure how long people can still be contagious. So it's the constant vigilance with, you know, the supervisors and the staff as we're walking through the floor to make sure that everybody is continuing on with the PPE. Thank you.
Thanks, Loretta. Oh. For some reason, it's not moving. Okay. So, so I think to summarize, obviously, I'm not going to summarize every area of PPE, cohorting, testing, staffing, and emotional distress symptoms that Loretta and Kelly covered so nicely. I think all of you that provide care in long-term care facilities, if the cases in your community are rising, your facility is at risk. So be prepared as if you, and by that I mean your facility is going to get it. Expect bad outcomes in SNF populations. Yes, we heard about bad outcomes, but when they happen to your patients, it's no easier. Even when they happened to 2 patients who were already on hospice on our service, it was still a very dramatic loss for us. And, you know, if I may share, we had one patient who had COVID, beat COVID, was doing well, and then one fine day had hemoptysis, went back to the hospital, was diagnosed with lung cancer, comes back and dies within a week. So obviously she didn't die from COVID, but it was still kind of sad that she had COVID, made it through, and then ended up having a diagnosis of lung cancer. I think by now the guidelines have more clarity, but as we were passing through this terrible saga in real time, we had to filter a lot of these extensive guidelines, and you also have to align them to the goal suited for your facility. I think for us, cohorting worked only for a few floors. At the other floors, it was extremely difficult to manage. Be prepared for a lot of emotional distress on your teams. If you expect the emotional distress level will be here, it actually will be up here. So whatever your expectation is, it's going to be much higher than that. I think you're all already aware of PPE cohorting transitions and staffing issues. Now that we have guidelines to test and do surveillance testing more extensively, hopefully this will be better. And then also COVID fatigue. We don't have an imminent vaccine on site. We don't have any dramatic great treatments. So this is here, right? It's not going to go away for the summer as we thought. It's going to be here with us for months, years, God knows how long. So prepare yourself accordingly, because I shared the terrible stats of almost 199 cases in a facility that initially started with about 370 census, and now our census is in the early 300s from all the losses and loss of admissions as well. So even though this facility, the fire seems to be settling down, we have 2 other facilities where the fire is just beginning. So I think we all need to be prepared for that, you know, this is a marathon, and we need to sort of ration our resources and our emotional energy and our medical energy for all this in the long run. So I'll stop here, and the 3 of us will be happy to answer any questions.
Thank you for sharing all of that. I've been watching the chat, and you do have questions to answer, and I think everyone has some questions that I think there were some posed for everyone to contribute to. But let me go back. Kelly, I believe it was when you were talking, and I'm not sure if this was addressed, but do you require that new admissions be tested prior to being accepted for admission?
Yes, currently that is the case.
Okay, thank you. I wanted to make sure that was addressed. And then there was a conversation going on between Juliet and Nicole concerning the gowns and the gown shortage. Nicole, do you mind if I put you on the spot, and could you speak to that a little bit for those who may not have seen the chat?
Yeah, sure. So there was a question about the appropriateness of using what sounds like hospital gowns as gowns for staff. And I actually was looking into this because there's still a severe gown shortage. Even when there's a COVID positive site and they make the call for a critical shortage to PEMA, they're not getting the gowns that they need. And so when you look on the CDC website, it's pretty loose. And it says that if you can't obtain, you know, the level 1 disposable gowns, they don't even say level 1, they just say disposable gowns, that they have a listing of acceptable options, which include lab coats and hospital gowns. And I think, you know, we would all agree that's not ideal. But I think there's recognition that even, you know, 2.5 months into this, we're still rationing PPE at nursing homes. And these sites are actively trying to find gowns, and they're not on the market to be had. The other problem is they don't have purchasing power. So a big health system that is going to order, tens of thousands of gowns has much greater purchasing power than these little nursing homes. And so, you're asking them to kind of fight a battle without appropriate gear. And so I guess that's a long response to a yes. Believe it or not, the hospital gowns are recognized as not ideal, but can be used if you can't access appropriate gowns.
Thank you. Thank you for following up with that. And I'm going to leave it with you because you posed some wonderful questions. So I'm just trying to go down in order. Do you want to go right into your questions?
Yeah, I mean, I had a question for the group, and I think Amy might have taken a stab at this. And this was brought up in the talk, and that is, you know, when to discontinue transmission-based precautions. So as the team alluded to, the testing-based strategy is not 100%. We've seen residents test negative and then a week later test positive again, you know, well out past even 21 days. And I know we have folks that were discharging from the hospital that were testing negative out past 30 days. What we don't know is the significance of that. Are they really still in, you know, do they still have a high infectivity level at that point? A lot of the studies, I was looking at one from Lancet last night, it looks like for most people, it falls off pretty dramatically by day 21, although there's a pretty steep drop off even sooner than that, but that's not really specific to elderly. And they do add caveats in the CDC guidance about immune compromised, which you could consider an elderly person. So telling nursing homes to follow transmission-based precautions that are kind of meant for the broader population seems really risky in a congregate setting. So if you get it wrong and people let down their guard because they think the person's clear, you know, you can be kind of adding fuel to the fire and have it start spreading again. So I've posed this question. I wonder if anyone else has any take. I know that at some of the sites, they're just saying, you know, after 14 days, even if they test positive, we're taking them out. There's concern about the residents feeling isolated and some of the emotional distress attached to that, which I fully understand. But I just don't know that the recommendations from CDC are 100% applicable to a nursing home strategy for discontinuation of transmission-based precautions.
Yeah, we'd love to hear what other people are doing because we are still doing testing, but the other community physician team in the nursing home that has almost 150 cases of COVID, I think, out of all the 199 we discussed, is basically watching for resolution of symptoms and declaring them recovered after 21 days.
So if anyone has anything else to contribute to that, please feel, Kelly, go ahead. Are you unmuted?
Oh, no, I just wanted to jump back to as far as the gown shortage. What we ran into because of the gown shortage, we were trying to just use the same gowns for all our negative patients that we thought were negative, and then using another gown for the positive patients. But what was happening was for some of the negative patients that we thought, they were actually positive. And then, so, you know, there's concern there of just spreading from a patient who was actually positive to others, even though you thought it was negative. So, I mean, the best thing is if every single patient or at least room could have their own gown to go into and out of. But, you know, we're doing the best with what we have right now.
I was just going to say, you know, I was just at a nursing home yesterday, and the challenge with that is, you know, once you go into a room, it's the gown's contaminated, right? So donning and doffing a contaminated gown is kind of dicey. I was talking with our ID doctor about that, and she kind of cringed. And, you know, it's one of those things where, you know, you're told to preserve PPE, and you're asking nurses that they're not, you know, they're not these infection prevention, they're not all infection prevention nurses. They're certainly not highly infectious disease trained nurses. And then you're putting them in a really high risk situation, asking them to don and doff a contaminated gown. So I don't, you know, I think that's the challenge that the nursing homes are facing, is that they're being put in a position to conserve, but it's also creating risk.
Yeah, I think just to share, Penn State Hershey, out of all the hundreds of cases of COVID they've only had 3 deaths. So think about that and put that next to 40 deaths in one facility only, where, you know, we've seen a terrible toll from COVID-19. So I think maybe people didn't see it coming, that the real ravaging will happen in nursing homes, and we were unprepared. I want to get to Amy's question.
Before we do that, can we go to Juliet's? I don't want to miss that one. It should be a quick one. Do we foresee family visits with residents being allowed outdoors in the future?
So I know at our facility, we've made that happen for some patients who were end of life. Kelly and Loretta, I don't know if you know of outdoor or courtyard visits for people in other situations.
So we're making arrangements for patients that are negative to go out into the courtyard. As far as connecting them with family, I don't know, that's not a huge thing yet. We're just trying to get the patients out so they're not, so they can have some fresh air and so they're not so isolated.
And we did have one patient who they brought her down to the courtyard and the family was way on the other side of the fence. And they did have a visit that way, but they were very, very social distance. They were not like that 6 feet that we're talking about for everybody else.
So I read that once the county moves into the green phase, 28 days after that, they will start loosening up some of the restrictions for the nursing homes. So it's going to be a while until it's recommended. Until then, it's the visitor restrictions. People are getting really antsy. I've been getting emails from assisted living facilities with families that want to take their loved one to a relative's wedding and how they handle that. And these sites are really, for all intents and purposes, still locked down. They're still like they're in the red phase. And so I think this is going to become one of those burning questions as society moves on to yellow and green. The families understanding that the nursing homes are still behaving as though we're in red, and how to manage that, and the social isolation and not being able to see your loved one in person for such an extended period of time. Certainly, the outdoor visits seem like they're far less risky than an indoor visit. But there aren't any current guidance coming out from DOH about loosening up the visitor restrictions.
And there was a comment that came into the chat regarding guidance restricted 28 days even after the county is green. But they're working guidance. So I'm sorry, Ayesha, if you want to go back with Amy and go through those questions, thank you.
Yes. So I think I'll get to the second part of Amy's question, which is post-COVID anorexia fatigue. I think we've definitely seen that. We did not end up using IV fluids on many of our cases. I think we were fortunate that many of them had mild symptoms. Correct me if I'm wrong, Loretta and Kelly, I think total of 5 got hospitalized, 2 died in the hospital. Am I right? And there was one unexpected death in the so-called recovery phase, as Amy put it in her chat. He was stable. He did not have any significant respiratory symptoms. He did not have any worsening hypoxia, tachypnea. He had breakfast. This is week 2 of his illness, back in early April when we were still beginning to find out about the thromboembolic and cardiac complications of the disease that set in week 2. And he was found dead after breakfast in his room. So it was very sudden, and I think that was a big jolt to all of us in the medical team. Looking back, I think it was not COVID pneumonia. It could have been an arrhythmia. It could have been a PE. But I think a lot of our patients settled with just oral hydration and got better slowly. If that answers your question, Amy.
Yeah, we held off on some Lasix, their usual Lasix dosage, and even increased the fluid intake, but yeah, no need for IV fluids on our patients.
Thank you for that. I've heard a lot about having to downgrade diets during this time. and careful hand feeding, increased needs for making sure there's adequate nutrition and hydration. All hands on deck.
The one thing I don't know, every site seems to be different. Some docs kind of subscribe to different recipes of medications. And I know zinc has been, one of them that I've seen added to the regimen. Zinc is highly nauseating, especially if you're not eating and then you take it on an empty stomach. And so I feel like sometimes are we doing more harm than good in adding these things with, they're otherwise not harmful, but in an older adult who already isn't eating because they're ill, and then we give them a medication that makes you nauseous. So I think there's a lot of well-intentioned efforts out there, but I also think you have to be mindful, classic geriatrics, of the side effects, and are you causing more harm than good? And so, that's I think another element to think about with the nutritional piece is, medications that they may otherwise be taking on after eating a meal that we're having to, give them or administer, and they're not eating, and is that causing symptoms?
Yeah, we didn't use anything fancy. We didn't use antibiotics except in a couple of cases. We used Avalox when there was an overt pneumonia. But obviously, I think it was a viral pneumonia, and we just kind of used the Avalox as an added precaution. We didn't do vitamin C, vitamin D, zinc. We didn't take people off their ACE inhibitors. We didn't have any subcutaneous hydration protocols. We did have a goals of care conversation with everyone who was newly diagnosed to reaffirm the goals, and kept updating them. And I think Loretta and Kelly, especially Loretta in the beginning of the crisis, did a lot of video chats with with the patients and the family members, and the recreational directors and the social workers helped with that. So
yes, they were a blessing to be able to get in there and, communicate with, for me to communicate with the patient, and as well as for the patient to see their family members. There was a lot more video conferencing between family members, and there was also a lot of window visits where they would take the patient down to the window, and the family would be down in the parking lot or wherever with signs and whatever it was that would make their family member happy. The social workers were great at whatever happened that they could possibly make happen so that people could physically see, even though they couldn't be near their family members.
So we have another few minutes left if there are any last questions or comments.
Hi, Mordecai Levy here. Quick question about kind of mobility, especially with the patients that were kind of COVID-19 positive. What kind of things did you all notice as far as kind of the decrease in mobility that people experienced? And was there anything that you found successful as far as kind of helping people move around more?
Well, that's hard because basically patients were supposed to stay in their room and be isolated from others. For the patients that did want to go out and they understood the risk, we made sure that they had their mask on, and they would get out also with physical therapy. Many of the patients I'm on a rehab floor were able to move about in their room and also the unit hallways with therapy assistance.
I think a lot of our long-term patients who got COVID that were not on the rehab floor were not mobile to start with. So, they didn't have any losses because they didn't have much to lose. But I think after this crisis is over, overall, I think our facility, long-term care, long-term residents would have lost a lot of mobility in between all of them.
Thank you for sharing.
Thank you for the question. Any other questions or comments? So feel free to put any last points into the chat. If we don't address them, then we'll get back via an email. I'll do some quick closing announcements, and then we'll make sure that we've answered everything. Just a reminder that you're able to collect CMEs for today. There will be a survey sent following the session. As mentioned earlier, all materials in the recording will be made available. And finally, please continue to watch your email for additional sessions that we are planning. So any last questions before you gain a minute or two of your life back to deal with what looks like storms coming?
Also, for all the medical and nursing teams, I think you can all look forward to wearing scrubs and bouffants and masks, and forget about your professional wardrobe for a long, long time. That's just an added lesson learned.
Well, thank you for that. All right, well, thank you, everyone. Again, we look forward to seeing you in the future, and feel free to reach out if you have any questions, comments, or suggestions for future topics.